Good afternoon, and thank you for joining us today for the Schedule Loss of Use informational webinar. I'm Jen Donovan with the Board's Communication and Outreach Unit, and I have with me the Board's Medical Director and Senior Policy Advisor, Dr. Elaine Sobelberger. In today's session, Dr. Sobel will provide training on the 2018 Impairment Guidelines approach to assessing SLU permanent impairment. We ask you to please keep your phone lines muted, as we will be using the chat feature to receive your questions today. To access the chat feature, hover over the WebEx tab at the top of your screen and click on Chat. We welcome you to enter your questions in the chat box at any time. However, please note we will be addressing all questions at the end of the presentation. One thing I would like to mention regarding the Q&A, due to the volume of questions we receive and because we want to focus on the content presented here today, we will not be addressing questions that deal with specific cases. There is a phone number that will be highlighted on the last slide that you can call with any additional questions, as well as a space to enter questions in the survey you will receive when the webinar is finished. So let's go ahead and get started. I will now pass it over to Dr. Sobel for today's presentation.
Thank you, and good afternoon, everybody. Thank you for joining us. Let's jump right in and look at what we hope to accomplish today. This training will help you apply the 2018 guidelines to assess residual, permanent physical and functional impairment in a worker with a schedule, permanent partial disability. We will learn the history of the guidelines, including changes from the 2012 and 1996 guidelines. I think this is important as a framework for understanding the evolution of the 2018 guidelines. In addition, we will describe the physician's important role in the medical evaluation of the permanent impairment and learn and apply some key terms and principles and approach to performing an SLU determination. And finally, perform some sample medical impairment evaluations using the guidelines objective criteria, and we'll look at some quizzes and case studies to help us apply the guidelines. In 1996, the board issued medical guidelines for the evaluation of permanent impairment for both scheduled and non-scheduled scheduled injuries. These were in effect through 2011. In 2012, the board issued medical impairment and loss of wage earning capacity guidelines known as the 2012 guidelines. These guidelines also address both awards, schedule and non-schedule, but in this guideline, this non-schedule criteria and evaluation was new. So the 2012 guideline contains chapters 2 to 8 for evaluating schedule loss of use. These come directly from the 1996 guidelines, and these are the chapters that are replaced by the 2018 SLU guidelines. Chapters 9 through 17 in the 2012 guidelines included what were then the new non-scheduled PPD guidelines. These remain in effect at this time. In 2017, there was legislation that directed the board to adopt revised guidelines for SLU injuries. These revised guidelines were to be reflective of advances in modern medicine that enhance healing and result in better outcomes. So, revised SLU guidelines were developed and implemented on January 1st, 2018. Again, just as a summary and a refresher, the 2018 guidelines, the introduction has been, from the 2012 has been replaced. However, chapters 2 through 8 from the 2012 guidelines, which were originally SLU, are no longer in effect, and the 2018 replaces these chapters. Chapters 9 through 17 from the 2012 guidelines for non-scheduled PPD remain in effect for the evaluation of non-scheduled injuries. Briefly, let's take a look at the legal framework, some important pieces of information that you need to know. First, New York State medical providers must be board authorized. When I say board authorized, WCB board authorized to treat and or perform IMEs. Permanency evaluations performed outside of New York State must be consistent with these guidelines. There are revised board forms which must be used to document SLU, and we'll discuss that at in the last section of the presentation. One of the frequent questions we've been asked during the transition is, when do you use the 2018 guidelines and when do you use the 2012 guidelines for SLU determinations? So let me clarify. When the first medical evaluation of SLU is performed before January 1st, 2018, the board will determine this permanent disability using the 2012 guidelines. If the first medical evaluation for SLU occurs on or after January 1st, 2018, the SLU determination will be made using the 2018 guidelines. Some of the questions we've received: is the date of injury that determines which of the guidelines? No, it's the date of the first medical evaluation. Is it the date that the IME is scheduled or performed? No, it is the date of the first medical evaluation that determines which of the SLU guidelines is used. Briefly, I'm including a table of contents for the 2018 guidelines. I think it provides a foundation for identifying where various parts of the body are located in the guidelines. And I want to highlight the fact that chapters 10 and 11 have not been changed from the 2012 guidelines. So they're included and they're moved forward so that we have all of the SLU components in the 2018, but these two chapters are unchanged from the 2012. Now let's take a look at the introductory chapter, which contains key concepts and terms. First, let's take a look at impairment versus disability. Impairment is a purely medical determination made by a medical professional and is defined as any anatomic or functional abnormality or loss. It requires a complete medical examination and accurate objective assessment, and residual impairment is considered permanent at MMI. Disability, on the other hand, is a legal determination that falls within the purview of the board and the workers' compensation law judge and reflects the impact of a workplace injury on a worker's ability to work. A workers' compensation law judge establishes a level of disability based on the available medical evidence and other relevant information. Maximum medical improvement is defined as an assessed condition of a worker based on a medical judgment that the worker has recovered to the greatest extent expected, and the corollary to that being no further improvement in his or her condition is reasonably expected. A few additional facts regarding MMI. The need for palliative or symptomatic treatment does not preclude a finding of MMI. And in the absence of surgery or fractures, MMI cannot be determined before 6 months unless parties agree. Next, let's look at the structure of each of the SLU chapters. Each chapter contains the following sections, and we'll go into what these actually contain as we move forward. So For objectives for determining impairment, initially each chapter in this section provides a brief overview of the function of the involved joint, and then goes on to say that that you need to accurately assess the permanent residual deficit from the work injury. And actually, that's what the guidelines are all about, this accurate assessment. And I'm going to say the obvious, the next bullet is obvious, it's standard medical practice. The assessment should be based on objective findings determined by history, exam, and results of any appropriate diagnostic testing. Once more, the determination of the degree of permanent residual physical deficit should be performed at MMI. Now I'm going to highlight when there's some new pieces of information. So the next bullet, when evaluating the level of residual impairment, the contralateral side should be considered for comparison for expected normal values when appropriate. And we'll delve into this a little bit more, and we'll address it in some of our case studies. The severity of a permanent impairment is not based on the mechanism of injury, and this is important. It really reflects the permanent residual that occurs at MMI and may include damage to a variety of tissues, including bone, muscles, cartilage, tendons, etc. The duration of time to MMI varies, and in most cases is 1 year from injury or last surgery. We're going to return briefly to the introductory chapter, which focuses on the physician's role. The physician's critical role is to provide the board and all involved parties with the best professional medical opinion regarding a worker's SLU impairment. It's expected the physician will use the detailed criteria in the guidelines to determine the severity of the impairment, and once more to reiterate standard practice to look to objective findings of the physical exam and data contained in the patient's medical record. New is the requirement that in the report physician identify the affected body parts, including the chapter numbers, and review the applicable sections that have been utilized. In addition, to review the relevant medical records, perform thorough history and physical exam, and then report the work-related diagnoses and reference the relevant information. Basically provide the documentation to support the SLU determination. And critical is to follow the recommendations in the guidelines to establish impairment level. And I think as we go forward, you'll see how some of the forms were modified to make it easier to provide the information that's required. Next, let's turn our attention to range of motion criteria. And the range of motion is a key factor in the SLU determination in the 2018 guidelines. Generally, a goniometer should be used to measure active range of motion. And the following are new requirements. 3 repeat measurements should be taken of the active range of motion. Deficits should be compared to the baseline reading of the contralateral member. So you're going to compare range of motion deficits to the contralateral baseline. Some other new requirements, using the contralateral side is not appropriate where the opposite side has been previously injured or is not otherwise available for comparison. When the contralateral side is not available or not appropriate, the range of motions designated, the normal range of motion designated in the 2018 guidelines should be used as the baseline comparison. So let's take a look at quiz number 1. Provided documents that an injured worker can only achieve 150 degrees of flexion in the healthy, unaffected right shoulder. The guidelines state anterior flexion in a normal shoulder is 180 degrees. And I just want to preface all of the quizzes and the case studies with the following statement. I did not include 3 ranges of motion in these examples, but the premise is that 3 measurements were taken, and what you're seeing in these cases and quizzes is the highest range of motion value. In determining the SLU for the injured left shoulder, the starting point would be 150 degrees, 180, or neither. The answer to the question is 150 degrees. Why? When evaluating the level of a permanent residual range of motion deficit, the provider should compare the range of motion to the contralateral unaffected side. When appropriate, the contralateral value should be the norm used to calculate the SLU percent. And we'll delve into this a little bit more in the next quiz. And in this quiz, an injured worker has a right shoulder that was normal prior to a work injury. The unaffected left shoulder has a forward flexion of 140 degrees due to body habitat restrictions. According to the guidelines, normal shoulder forward flexion is 180 degrees. The right injured shoulder attains forward flexion of 45 degrees. What is the right shoulder SLU? A, 60%, B, 78%, or C, 47%? And the answer is C, 47%. And let's see how we arrived at that. Flexion of the unaffected shoulder, 140 degrees, becomes the baseline and is used to calculate the shoulder SLU. So we have 140 degrees, which is the unaffected contralateral range of motion, over 180 degrees, which is normal, and we do a ratio and come up with a percentage of 78%, which is the ratio of the range of motion of the unaffected shoulder versus the normal range of motion. This becomes the baseline. This is an excerpt from the shoulder table, and if you take a look, you can see that the range of motion for this patient would fall into a marked or 60% category, and at range of motion 45 degrees would equal 60%. However, if we do the calculations, the worker's baseline range of motion represents approximately 78% of the normal range of motion. So the worker's SLU, which would start at 60% from the table if the worker had had a normal 180-degree range of motion, would be multiplied by 78% to give you a 47% SLU based on the worker's contralateral baseline range of motion. Now let's look at some of the rules for range of motion deficits. And these 3 bullets are new. Actually, the 3rd bullet is really a modification of our 2012 guideline rules. But let's look at the first 2 bullets first. For SLU determinations based on range of motion, the total SLU for several range of motion deficits within a joint cannot exceed the value of full ankylosis of the joint. Taking it to the next step, when there are multiple ankylosed joints, the sum value of the SLU of major members cannot exceed an amputation value for that member. And the exception to these rules is loading. Loading exists from before, but there has been one change in the rules, and we'll get to that in a little while. One of the enhancements in the 2018 guidelines are the written instructions and visual aids that were developed to properly measure all range of motion deficits within the joint. And as an example, let's take a look at Chapter 5, and I think you'll see the specific instructions as well as the diagrams aid in clearly defining how the measurements should be made. So here we're talking about flexion and extension. We define how it should be measured, and then on the next slide you'll see the diagram, and we clearly define what we're measuring and what the normal ranges are for these measurements. In addition, another clarification has been the clear identification of mild, moderate, and marked defects that are associated with a % loss of use. And in this case, let's take a look at the next slide, and we use the wrist range of motion, and you'll see before we go to the actual table, clearly defined are the % loss of use with the associated degrees, and in the table, this is further documented. In this case, we highlighted the moderate, and I think it's clear that the relationship between the % loss of use and range of motion is pretty easy to identify. The 2018 guidelines contain step-by-step explanation to bring consistency to the concept of loading. And the significant change that's been made in loading is that there's been an increase by 20% to address the increasing reliance on the hand and fingers in the computer age. There have been some changes in special considerations, and I can't go into each of them, but I just wanted to identify certain overarching changes. Instructions have clarified whether a condition that falls under a special consideration is a standalone or an add-on value. Certain changes have occurred. For example, the special considerations for meniscal and rotator cuff tears with or without surgery have been removed from the special consideration sections. I think a significant and major change has occurred in terms of joint replacements. Advances in medicine have improved many joint replacement outcomes, and the 2018 guidelines have established criteria, clinical criteria to look at the outcomes of a joint replacement. And these clinical criteria include an overall grade, range of motion, position, atrophy, and complications. In addition, the starting point for an SLU in a joint that has had a good outcome is 35% of an SLU. Additional deficits would be added to this baseline of 35%, and then in addition, the additional deficits would be chosen from the relevant columns that had the closest matching a deficit to the patient's deficits. And we'll do some examples. Let's take a look at quiz number 3. A worker is status post hip replacement surgery. At MMI, the following clinical findings are noted. There's a range of motion which is more limited in flexion to 45 degrees. There's a leg length discrepancy of 0.8 inches, and malrotation is present at 20 degrees. The SLU determination for this patient is A, 35%, B, 55%, C, 45%. And the answer in this case is 55%. The value of a hip replacement starts at 35%. There is an addition of 10% for flexion deficit, and there's 10% for malrotation, which will bring you to a total SLU of 55% based on the facts of this case. Looking at the table, that would be the appropriate table. 6.5 is hip replacement. And I noted that the 35% is the starting point. In this case, the patient's range of motion fell into the fair category, 45 degrees, and it says you add 10%. The malrotation falls into the poor category, and if you look at the leg length discrepancy and or greater than 15 degrees rotation, the malrotation of 20 degrees falls into this category. So you'd have 35 plus the 10 from the range of motion plus the 10 from the malrotation, and you would end up with the 55%. A few other pieces of information about the tables. Some of the tables have a range of motion for a percent, and when there is a range of motion, the lower value would be used when only one range of motion, there's only one range of motion deficit in a joint. When there are two range of motion deficits, for example, both flexion and extension, then the higher percentage would be used. So we'll take a look at Table 2.5b. And if you look, in this case, we decided to take the MCP joint, and the range is 30 to 40 degrees. So if only flexion were involved, for example, then it would be a 30% SLU. If both flexion and extension were involved, then it would be a 40% SLU. This is another new and important piece of information. In the shoulder, if there is documentation of a deficit in both flexion and abduction, the greater of the two deficits must be used in the SLU calculation, not both. So now let's walk through the process and highlight the new requirements. First, the first step is to determine whether or not a condition triggers a special consideration. If it does, then obviously you'll perform the SLU determination consistent with the requirements in the special consideration section. If the condition is not listed or not addressed as a special consideration, then the SLU evaluation should proceed according to the guidelines general criteria for the body part under discussion. And some of this now will be repetitious, but I think it's important because these are kind of new concepts and need to be clearly documented, so let's walk through them. Again, range of motion values for affected joints should be documented according to the guideline instructions. The location, the chapters and the sections that are being utilized should be identified, and 3 repeat measurements of active range of motion should be performed using the goniometer. All 3 measurements should be reported, and the highest of the 3 measured values should be used in the SLU determination. The physician can use a measurement other than the highest value, but needs to explain in detail why the highest range of motion was not appropriate for the calculation. Now some information about the contralateral measurements. As a baseline, range of motions for the unaffected contralateral joint, if appropriate, should be documented and should be utilized as the baseline for the SLU determination. There are times that the contralateral side may not be appropriate if there's been a prior injury or even an amputation. That would make it difficult to have a comparison. If the contralateral side is not appropriate, an explanation should be provided. In the event that the contralateral side is not available for comparison, then the normal ranges should be taken from the 2018 guideline tables and should be used as the baseline under those circumstances. Generally, range of motion deficits or defects will correlate as follows. A 25% loss of use would be a mild, 50% moderate, and 75% will equal a marked. So let's look at case study number 1. We have a 53-year-old man with a work-related injury to the right shoulder, and his status post-right rotator cuff repair. His injury was precipitated by lifting a 40-pound box to shoulder height, and he felt a sudden pop with pain and weaknesses in his right arm. Surgery was a year ago. He's at MMI and working. Prior to surgery, he has full range of motion in both shoulders. On physical exam, the incision is well healed, there's no atrophy. Range of motion, the forward flexion is 0 to 90, abduction is 0 to 100. There are mild defects in external and internal rotation, and the left shoulder has full range of motion. And full range of motion in this case would mean 180 degrees, just utilizing the table from the 2018 guidelines. Well, I'm repeating myself. I'm consistent. The contralateral shoulder has range of motion, full range of motion, so we're talking 180 degrees. And in this table, you'll see the flexion and abduction. And in this case, abduction of 100 and flexion of 90, which is the lesser value, falls into the moderate category and would give us a 40% SLU determination. However, there's some additional information that is required. Under the table in the guidelines, there are notes. And in this case, the notes state that if the abduction and, well, first of all, we talked about the abduction and the flexion using the greater deficit. But if the deficits are in the moderate range and within 10 degrees of each other, an additional 10% can be added to the value of the SLU. Mild deficits of internal and external rotation are not added to avoid cumulative values. So, summing this up, the flexion deficit is the greater deficit, falls into the moderate category and gives us a 40% SLU. Deficits in within 10 degrees of each other, so an additional 10% may be added, and internal external rotation mild deficits are not added, and just as a special note, there is no longer a special consideration for rotator cuff tears. So the total SLU would be 40% plus 10% equals 50%. Okay, our second case study is a 59-year-old woman whose status post right total knee replacement. Surgery was over a year ago, and it's been determined the patient is at MMI, and she returned to full duty as a bus driver without restrictions. The right knee, the incision is well healed. Range of motion for flexion is 125 degrees. There's full extension to 0 degrees. There's no instability and no atrophy. If you take a look at table 7.5, which is a table for knee replacement, and you go to the overall assessment grade of good or A, you'll see the range of motion of greater than 105 degrees, an extension of less than 10 degrees. Patient falls here. You'll see there's no rotation and there's no atrophy, so this patient is fully in the good category, and the SLU in this case will be 35%. Now let's turn our attention to the revised forms. there are several revisions. We'll look first at the doctor's report. The C4.3 has been revised slightly. The new components are two attachments. There's Form C4.3A, which will be used to document an SLU determination, and C4.3B, which will be used for the non-scheduled PPD assessments. For the IME, the cover sheet has been modified slightly, and here too there are parallel attachments to document the SLU Form IME 4.3A and non-scheduled impairment Form IME 4.3B. The C4.3, this is for physicians now, the C4.3 will continue to be used as kind of a baseline starting point for the submission of the impairment report, and the attachments should be added to the C4.3, and again, we're going to focus on attachment A today. Attachment B for non-scheduled loss of use reflects the criteria and information that come out of the non-scheduled PPD evaluations in the 2012 guidelines. Attachment A reflects the criteria for documenting SLU determinations according to the 2018 guidelines. I'm including this patient information A, not because it's changed. I'm highlighting the date of injury or illness. And I think it's important that I emphasize that a provider should address any of the body parts or conditions that relate to an injury, to a date of injury as listed in A6 here. And so this would include scheduled and non-scheduled losses that might occur as a result or related to that date of injury. D hasn't changed, but Section E has some new components, and they are highlighted in yellow. So attachment A would be used to complete any SLU loss, any SLU evaluation except for serious facial disfigurement, vision, or hearing loss. Some of those assessments can be an attachment, a narrative attached, or as you can see on the next slide, hearing loss can also be documented using the C72.1 for occupational loss of hearing. Traumatic loss of hearing would be the C4.3 with an attached narrative. Vision loss would be addressed on the attending ophthalmologist report, C5, Form C-5, or alternatively, a C4.3 with an attached narrative. And similarly, serious facial disfigurement would be a C4.3 with an attached narrative. Now let's turn our attention to the C4.3A, which is the form that would be used to document the SLU assessment. And again, note that you must complete this attachment for all body parts and conditions for which you treated the patient for the date of injury listed in Section A6. Just wanted to emphasize that. It's a recurrent question and a recurrent theme in some of the questions that have come up through the webinar and outside of the webinar. I can't emphasize this piece enough. The form, the C4.3A was modified with the documentation criteria in mind. And the requirements for the documentation are listed in these bullets. And they reflect all of the information that I've emphasized and re-emphasized. For example, if you look at the second bullet, it emphasizes the fact that you need to provide 3 measurements for the injured body part and use the greatest range of motion. And if you don't use it, please explain why. And similarly, the request for information regarding the contralateral body part. The emphasis is on providing the information as required. And of note and concern, if the required information is not easily, not available and easily understood, it is very possible that a report could be precluded by a judge of the board for lack of the required documentation. The choices for documenting the required information are, one, to complete this grid, and it really flows consistent with the requirements, or in the alternative, a narrative can be attached as long as that narrative contains all of the required documentation for all of the body parts that are related to the date of injury in A6. The independent medical examiner's cover sheet, the IME-4, has a change, and basically at the bottom of this section, the start of the patient exam, the end time of the patient exam, and the total time spent reviewing records is being required. Part of this information is coming out of a legislative mandate to perform an IME study, and this is some of the information that is necessary. The IME medical examination, this is just a general statement. None of the policies, procedures, or processes associated with the independent medical examination, for example, who do you copy, what is the information that you include, none of that has changed. And the only thing that has changed is that if you're dealing with an SLU, you should complete 4.3A, or if you're dealing with a non-schedule loss of use, you should complete the IME 4.3B, or provide a narrative with all of the information. If you take a look at the actual the IME 4.3A for the SLU, you'll see that it mirrors or parallels the changes that are in the C4.3A, the identification of the information that's required. The bullets are there as a reminder of what must be included in the medical narrative should you decide to use one, and to ensure that, or if you don't use the medical narrative, if you decide to use the form with the grids, then to ensure that each grid is completed. And this is a grid, again, parallels the treating physician's documentation as well. And that's the end of the presentation. There are some resources here. Workers' compensation, the actual guidelines are available on the board's website, as is a recent subject number regarding the forms. And I guess I should, before I completely end, provide some information regarding the forms, because we've had a lot of questions and requests for clarification. The subject number that went out initially indicated that the new forms would be available and had to be used as of May 16th. The clarification that we've made, Gov Delivery notification went out yesterday, and the bottom line is, at this point in time, none of the forms will be precluded. You can use old or new forms for submitting your SLU determination, as long as all of the required information is included. If the IME is using an old IME-4, the information regarding the timing of the exam and the length of time for record review must be included in the report as well. In July, there's an expectation that the forms will be available electronically, and at that point in time, there will be a mandatory use of the new forms, and you will be notified when that happens.
Okay, thank you, Dr. Stovall, and thank you, everyone, for your participation today. Just a reminder, we will be making a recorded version of the webinar available on the Impairment Guidelines section of the board's website tomorrow, and we'll inform you via WCB notifications. To receive notifications, visit the board's website at wcb.ny.gov and click on Get WCB Notifications on the bottom of the home page. Once you exit this session, you will be presented with a brief survey to provide your feedback on today's training. As previously mentioned, there will be a section in the survey for you to enter your questions and your contact information so we can get in touch with you regarding the answers. Also, keep an eye out for an email with the survey link as well. We thank you again for joining us today, and have a great night.